Hi everyone, welcome to lecture 1, part 1 on the practice of medicine. So in this lecture is based on the Harrison's Principle of Internal Medicine, volume 21, and it's basically taken from chapter 1. So I've read the Harrison's textbook of medicine, so you don't have to, because the content present in this lecture is reflective of the content that's in the textbook, excepting that it's presented in a more comprehensive manner with pictures and so on. And I hope you would find it very beneficial, whether you're a doctor, a nurse, or medical student, or someone who's interested in medicine and internal medicine. I hope you find this video beneficial. And also, please, if you like this video, consider liking and subscribing to my channel. It would really benefit me um, and support me in building my channel and also supporting me in creating other videos in the book because it's very time consuming. All right, so this is the outline of the lecture today. We're going to first talk about the science and art of medicine. We're going to talk about clinical skills, aspects of history taking, physical examination, and diagnostic studies. Then we're going to talk about the management of patient care, team-based care, the dichotomy of inpatient and outpatient internal medicine, differences between them, mitigating the stress of acute illness, especially when patients are hospitalized. We're going to look at medical decision making. We're going to look at practice guidelines, what they mean. We're going to look at personalized precision medicine. We're going to look at the outcomes of patient care, um, errors in the delivery of healthcare, and some electronic medical record systems. All right, so here's a quote from the book that I really like. So it states that there's no greater opportunity, responsibility, or obligation can fall to the lot of a human being than to become a physician. In the care of the suffering, that's the physician, needs technical skill, scientific knowledge, and human understanding. Tact, sympathy, and understanding are expected of the physician, for the patient is no mere collection of symptoms, signs, disordered functions, damaged organs, and disturbed emotions. The patient is human, fearful, and hopeful, seeking relief, help, and reassurance. So this is important. As physicians, we have a great responsibility for human life. And when patients present to us, they present with real fears and the fear of their life. And the least we could do as physicians is to relieve their suffering. Medicine in 2023, it is an evolving science, continually evolving and enduring trust. So we have many scientific advancements like genetics, advanced imaging these days, robotics, and these things revolutionize modern medicine to what it is today. The information explosion requires constant learning for healthcare professionals. New research are coming out every day and guidelines are continually changing. So it's important for medical professionals and doctors in particular to keep up with the new evidence that's coming out in these studies. Electronic records and the internet certainly provide new ways to access and share information these days. But despite all of this scientific progress, um, the physician-patient relationship remains the same. Um, it's really, really important to provide patients with very compassionate, empathic care for optimal outcomes. All right, so this is a slide just showing us some scientific advancements these days. So this is an example of next generation sequencing, which allows us to very quickly screen the human genome looking for any mutations that may cause genetic diseases and cancers. And this here is an example of robotic surgery that allows surgeons to perform surgeries without with more precision and even be in remote locations and perform these same surgeries. This is an example of advanced imaging that also allows radiologists to perform interventions if needed. And this is Epic. Well, this is a very popular electronic medical record system which allows data to be recorded very efficiently and allows for intercommunication between different medical institutions. All right, so this was taken from the textbook also. This is a painting known as The Doctor by Luc Fidels. It depicts the caring relationship between the Victorian physician and a very ill child. And it was painted in 1891, and the painting reflects the death of the painter's young son from typhoid fever, and it was intended to reflect the compassionate care provided by the physician even when his tools were not able to influence the course of the disease. So this is also applicable today, even though we have all of these scientific advancements and tools, imaging tools and genetic testing and so on. Providing compassionate and empathic care remains the cornerstone for medical practice. All right, so this is how technological advancements could help to transform healthcare delivery. So when we have clinical problems, um, we could use technology to help find solutions for those problems. Um, there's advancements in various fields like biochemistry, cell biology, genomics, imaging, and they provide deeper insights into the body. For example, we have the MRI, and that was able to visualize soft tissues better. And that definitely helped to improve on the diagnosis of many conditions. Understanding genes and single cells leads to new understanding of system physiology. Unraveling gene regulation, genetic changes could affect cells and organisms. And we've seen that. We've seen how mutations could lead to diseases. Um, Clinicians recognize the importance of stem cells. So there's a lot of ongoing stem cell research, and we could use stem cell to treat certain conditions also. Um, We have entirely new areas of research like studying the human microbiome, studying epigenetics, and studying non-coding RNA regulation. And we could use these things to help improve on human health and diseases. All right, we have big data analysis from medical records and omic data. It drives AI and machine learning for improved clinical prediction and decision making. So, nowadays, especially on the internet, and we have so much raw data available, and now we just have to make sense of this data. And that's why tools such as AI were developed to make sense of that data so we could see certain trends so we could make appropriate decisions for our patient. Um, Medical science advancements would translate into a deeper understanding of very complex diseases. It would allow us to develop new strategies for prevention, diagnosis, and treatment of conditions. And personalized medicine gets closer um, with refined omic signatures and clinical data. And later on, we'll talk about the concept of precision medicine and how we could develop targeted therapies for various phenotypes of diseases. And of course, technical skills alone definitely don't define a good physicians. We should treat patients as a whole, um, not only the medical aspects, but also the social aspects. And just reiterating that um, empathic, compassionate care that I mentioned earlier. Um, Vaccine platform advancements and new technologies like the cryo-electron microscopy um, accelerated vaccine development, particularly during the COVID-19 pandemic, and we'll see more of that on the next slide. All right, so this is a little bit about cryo-electron microscopy, also known as cryo-EM. So what is this? Cryo-electron microscopy is an advanced imaging technique used to study the structure of biological molecules like proteins and viruses at near atomic resolution. And this is an example of how a cryo-electron microscopy looks like in this image. And this imaging technique has revolutionized various fields of research like drug discovery, understanding the structure of protein, especially that three-dimensional structure, and that could help design new drugs that target specific molecules, particularly looking at the receptor site of drugs. Virology also, in studying the structure of viruses that can aid in vaccine development and understanding viral mechanisms. We'll see an example of this on the other slide. It's helpful in cell biology also in understanding the structure of cellular components and provide insights into cellular processes and diseases. We could see here that the impact it had on the COVID-19 vaccine development. So it played a very crucial role in the rapid development of the COVID-19 vaccine because this type of microscopy enabled scientists to actually visualize the spike protein that was present on the COVID-19 virus, and that allowed them to design vaccines that effectively targeted this protein. So these are images that shows us the differences between what transmission electron microscopy looks like. Basically a black and white image, and it's two-dimensional. And this is what cryo-electron microscopy look like. You can see that the images are more 3D, so it could demonstrate a three-dimensional structure of proteins and receptor sites. Here is an example of cryo-EM being used to visualize the different subtypes of the spike protein on the SARS-CoV-2 virus, and you could see how it's able to tell the different subtypes apart. This is really helpful in the development of the COVID-19 vaccine very quickly during the pandemic. Alright, so medicine is indeed an art, and in clinical practice, physicians usually face very challenging situations. There's a lot of complex cases with overlapping information. This is really telling us that patients typically don't present like the textbook would say that they present. They would have a lot of different signs and symptoms and present atypically oftentimes. So these various skills are really needed by physicians. So physicians need to discern key details from the history, exams, and tests, and order appropriate diagnostic tools like labs and imaging just to confirm what was obtained from the history and the physical examination. A lot of information would be provided, and a very skillful physician is able to extract crucial information from the data. It's important to differentiate between if you should treat the patient or just do watchful waiting. Sometimes it's better to not treat and just to wait. In many cases, for example, like the common cold, we typically don't treat that. It usually resolves on its own, and that's something we would be able to advise our patients. Um, it's important to distinguish between relevant clues from irrelevant findings. Some findings patients might present with might mislead us, and a very skillful, experienced physician would be able to detect that. And we should weigh the risk and benefits of interventions. For example, when prescribing drugs, we should be aware of and take into consideration the side effects of those drugs. So, all in all, the art of medicine combines knowledge, intuition, experience, and judgment, and it remains critical for effective clinical practice, even in the age of advanced science and data. Now let's look at some clinical skills. All right, let's begin with history taking. So, what is history taking? It's pretty much an interview with the patient, um, finding out more about the patient's chief complaint, um, just to get to the bottom of the issue that the patient is having. Some aspects of history taking is gathering all the relevant details, focusing on recent events, particularly the chief complaint that the patient is presenting to you with, and just listening to the patient's full story. It's important to ask open-ended questions in the history in the interview and allow the patient to tell you their story. Throughout the process, it's important to show empathy, empathize with the patient, show interest, because oftentimes their complaint is going to be causing social occupational dysfunction and distress. No detail is too small. Seemingly trivial information may be crucial. That's why it's important to be thorough throughout the history-taking process. Um, a review of system is important too. So the reason why we do this is we're screening the patient's system, asking for common presenting complaints from every system. So that's just to ensure that nothing's missed that the patient might not be thinking of. Patient comfort is key, and building a report um, is important to obtain more complete information from the patient. A good rapport with your patient is going to make your patient more comfortable to disclose certain confidential information to you. And the result will be a comprehensive history will improve diagnosis and patient well-being. All right, so taking a history is the key to establishing a strong patient-physician bond, understanding the patient perspective on their illness. Sometimes patients might have skewed perspective as to what a disease entails, and you as a physician would be able to offer them clarification on that, recognizing their expectations and concerns on they encounter, appreciating the impact on the patient's life. The patient might be, the disease might be impacting the patient's job, for example, and might be affecting the patient's finances. So all of those things you would like to know as a physician. Prioritize quality over speed. A rushed encounter can can discourage full disclosure, and this is something can be very hard to achieve in a clinical setting, especially in those settings where there is a high patient volume and limited time. But confidentiality is vital. It is important that you tell your patient that everything that is said between you and your patient stays between. So ensure that you um, establish that confidentiality. So your patient would be more comfortable to disclose vital information that might lead to the diagnosis. So the result is building trust through a thorough history leads to better patient care and stronger relationship. All right, so this is an example of what a SOAP note looks like. So a SOAP note, subjective, objective assessment plan. This is a format in which you document the information obtained from the patient. So medical students would be using this format mostly to document their information. It gives a nice framework onto which you could make documentations. The subjective portion is the information that the patient tell you. It includes the chief complaint, the history of presenting illness, which is this paragraph, and the rest of the history, like the patient's medication history, surgical history, past medical history, and so on. The objective portion of the SOAP note is the information that you would obtain from the patient, like the physical examination and vital signs obtained. The assessment are the differential diagnosis that you have in mind after conducting the history and physical examination. And the plan are the investigations like blood tests and imaging that you would like to perform on the patient to confirm your diagnosis. All right, so the physical examination portion of the encounter, the goal is to identify physical signs of disease, um, most valuable when confirming already suspected issues from the patient's history. So usually the system that you're going to be examining is going to be based on what the patient complained of. For example, if the patient complained of chest pain, for example, you're going to prioritize examining the cardiovascular system, the heart, for example. Unveiling the hidden, it can also reveal disease not mentioned in the patient's narrative, and this is more so for a generalized physical examination, examining most of the system, if not all, looking for any other evidence of any abnormalities that the patient might have. Together, the history and physical examination provide a comprehensive picture for accurate diagnosis. All right, so these are some principles of physical examination. You should try to be methodological and thorough. Try to do a complete physical examination from head to toe. Although this might be difficult sometimes in the clinical setting, we should strive to be as thorough and complete as possible, just so that we don't miss anything. We should also pay attention to patient's comfort and modesty um, when examining a patient. So appropriately drape your patient and protect the dignity of your patients. Um, Detailed documentation. So documentation is going to be really important. Um, Record findings immediately to avoid memory bias. So you don't want to check the pulse and then about hours later then you go to document. You'd want to document that right away because you don't want to put um, a finding that's not accurate in the patient's records. So continuous learning, seek guidance from experienced clinicians and utilize simulation tools as practice. Um, Goes beyond technique, so develop a keen mind to interpret subtle findings like few scattered petechiae, a faint diastolic murmur, or a small mass. What this really means is we have to be intentional when we are doing physical examination. So, for example, if you're going to palpate an area, you have to be intentional in um, going to look for a small mass, for example. If you listen to the heart sounds, you have to be intentional listening for a diastolic murmur. If not, it's easily missed. Regular re-evaluation, repeat examination as needed to monitor changes. Um, this is especially important in patients um, who have diseases and physical examination findings could change really rapidly. So remember, effective physical examination goes beyond technical skills and prioritize both thoroughness and patient's well-being. All right, so this is a slide showing us the use of simulation in medical practice. So this is where students, doctors, um, and so on could practice on a mannequin. Um, they could practice physical examination and um, in, procedures so that they become a bit more comfortable and confident before approaching a real patient. You could make your mistakes on the mannequin, but you would try not to make mistakes on real patients. So that's the importance of simulation tools being used in medical practice. All right, so while advanced tests do exist, don't underestimate the value of a very thorough physical examination. Critical findings might be missed by tests, and physical examination can reveal important information even when tests are negative. So there are certain disorders where they're only diagnosed once a patient has a negative physical examination. Those are diagnoses of exclusions where no organic pathology is actually present in the patient. So some examples of these disorders are anxiety disorders and irritable bowel syndrome, for example. Physical examination helps to put lab results in context also, so it could help to determine if a lab value is truly relevant, or you could disregard that lab value or even doing a repeat. So for example, if a patient has a low hemoglobin, if the results come back saying that a patient has a low blood count, you could perform physical examination on the patient to look if there's any pallor, for example, on the patient's mucosa, which could confirm this low HB on the laboratory testing. A physical examination definitely would help build rapport and trust with patients and strengthen the patient-physician relationship. And we should not rely only on tests. It's important to perform a thorough history and physical examination and just use diagnostic tests to confirm what you already suspect from the history and the physical examination. All right, so now we move on to the use of diagnostic studies in the practice of medicine. And while advanced tests are valuable indeed, they shouldn't replace the importance of a thorough clinical observation. Careful examination is crucial to capture crucial details. We should understand test limitations also. Tests are not infallible. Every test carries with it sensitivity and a certain specificity, and we should be aware of these things too. An interpret result requires awareness of these potential errors. Consider the cost benefit effects also. Weighing the expense of tests against their potential value is essential. For example, if you're going to be ordering a very expensive test like an MRI, just think about how it's going to benefit the patient and if it's going to lead to the underlying problem, for example. And remember, a comprehensive approach combining observation, examination, and appropriate test utilization leads to better diagnosis and patient care. All right, so the power of panels. Single tests are rarely done. Physicians often order groups of tests in the form of panels, and I'll show you some examples of panels on the next slide. This is done for efficiency and cost effectiveness. If you order multiple tests in one specimen, multiple tests could be performed from a single blood draw. So you don't have to bring the patient in back multiple times and stick the patient with the needle multiple times. So it could be done on one specimen. Um, it could uncover hidden clues also. So for example, if a patient presents to you with weakness and fatigue, and the test shows that there is elevated liver enzymes, for example, that could point to conditions such as chronic liver disease, explaining those very constitutional and non-specific symptoms. So that's one thing that's really helpful um, to get to the bottom of the issue that the patient is having. And you could also pinpoint specific issues. So, for example, if you do your panel and you found out that the patient is having a high calcium level, that could actually suggest that the patient might have a underlying parathyroid issue like hyperparathyroidism. And from there on out, you can go looking for the problem. For example, you could do imaging of the parathyroid glands and see what's going on, for example. So panels offer a comprehensive picture and they do enhance diagnostic accuracy and efficiency. Here are the common blood test panels, some examples. So we have very commonly ordered panels, basic metabolic panel, which tests electrolytes, things like your sodium, potassium. It could measure glucose, measure kidney function tests from the creatinine, blood urine nitrogen, sorry, and creatinine, and calcium also. We could do complete blood count, which is commonly done. It assesses HB, your white blood cell count, the platelets, etc. Another panel that could be done is the lipid profile or cholesterol panel. It measures LDL, HDL, and triglycerides. You could have your thyroid panel if you suspect your patient to have thyroid abnormalities. TSH, T3, T4 are some components of this panel. Liver function tests, LFTs, AST, ALT, bilirubin, and you could test the patient's urine also by doing a urinalysis, which assesses the urine for protein, glucose, ketone bodies, white blood cells, and crystals. All right, and here we have some examples of imaging. So this is a specific example of brain imaging and the use of the X-ray, which shows us more bony structures. We have here the CT scan, which shows us bony structures as well as soft tissue. We have the MRI, which shows us both bony, but it shows soft tissue structures in great detail. We have the MRA, which is an angiogram. So the angiogram is where you would inject contrast in the patient's bloodstream and you take an image, you do an MRI on the patient, and it would basically highlight the vessels. And typical case where you would do this is looking for vascular abnormalities, things like Berry aneurysms or arteriovenous malformations and so on. And here is another example of PET scan where you would assess the metabolic activity of tissues. And this is typically used more so in cancer studies. All right, so screening tests, these are really important because it could help identify potential diseases very early for an early intervention. For example, if we screen a patient testing blood glucose levels, HbA1c, and we see them to be elevated, we could detect diabetes very early and start the patient on um, appropriate medication and lifestyle changes so they don't develop complications of diabetes, which is gonna really be beneficial for the patient. And also the same could be said for hypercholesterolemia. If a patient cholesterol is very high, we could introduce lifestyle and changes or put them on medication very early so to prevent later cardiovascular effects that could occur as a result of high cholesterol levels. Screening tests are targeted and cost-effective and is used for common conditions and guide further testing as needed. Common condition like diabetes, for example. We should also interpret these tests with caution. Occasional abnormalities may not exactly indicate significant disease. An example I have here is creatinine, which is a kidney function test. The creatinine value could actually flux with a patient's age and with a patient's body mass. So we should be aware of this when interpreting tests also. If we're unsure about the test, we could repeat it for confirmation also, because it could be a problem with the specimen, the actual specimen. It could be a problem with the laboratory equipment also, so we should be aware of these things. Consider the context. Evaluate abnormalities along with the patient's medical history and symptoms that they might have. We should not just look at the laboratory test in isolation. Um, and remember, don't jump to conclusions with single test abnormalities. Use them as a guide, definitely not a definitive diagnosis. All right, so the advanced imaging examples that we went through would improve accuracy. So it would enable us to obtain detailed information to make more informed medical decisions for our patients. It would offer a more non-invasive option, replacing more older invasive methods. For example, we have the MRI now, which is able to give us more details of soft tissues, and it can replace us doing a biopsy on the patient, which is a really invasive procedure. So that's one benefit there. It could definitely lead to faster diagnosis, and we should remember too the cost and potential harm of performing these diagnostic studies. Each test carries a cost and potential for complications, so some could be very expensive, and we should be aware, for example, that X-rays and CT scans poses a radiation risk for our patients, so we should keep those things in mind. Um, Unexpected findings, further investigation may be needed, leading to unnecessary procedures or irrelevant diagnoses. For example, if we order too many imaging studies for our patients, we may discover things that are incidental, right? And sometimes discovering these incidental findings could be good, but again, it could identify very benign lesions, like very benign cysts, which may lead to unnecessary workup and more invasive procedures to be performed on the patient. So we should keep that in mind also. A skilled physician should use imaging judiciously only when they will significantly impact a patient's care. And the risks and benefits should be weighed before ordering these investigations. All right, so now we move on to aspects of management of patient care. The first topic we look at is team-based care. So, teamwork is key. Medical practice has always involved teams. It's not only the physician managing the patient alone. Um, in that team, it includes the nurses, medical students, physician assistants, nurse practitioners, the pharmacists, and so on. Managing complexity, advancement in medicine allows us to handle intricate situations in the ICU, especially bone marrow transplant, and manage chronic illnesses. A patient may have multiple specialists based on the condition they have, and they may require care from several specialists. And it is important as a primary care physician to coordinate care between these specialists to avoid patient confusion, most importantly. Effective communication with patients is crucial. Although patients may have many specialists, it is important that these physicians maintain face-to-face communication and with the patient. Consistent messaging. So healthcare providers should strive to deliver unified messages to patients to avoid confusion. This is a really important point, and that's the importance of the primary care physician to be the person who coordinates care between all of the specialists. Um, Patient understanding. So management plans and treatment options must be explained concisely and clearly to patients. All right, so the allied healthcare team, like I said, it's not only the physician that cares for patients. It's a team-based effort. So expanding care, hospitalized patients encounter diverse professionals like physical therapists, pharmacists, social workers, and they all contribute. And beyond the hospital, in outpatient setting, for example, nurses, physician assistants, they play a crucial role in disease screening and chronic disease management. For example, it is nurses and so on that would actually perform pap smears on patients and mammography. And they are an important member of the healthcare team. All right, team-based care necessitates changes in medical culture, student training, and healthcare system organization. Um, Healthcare professionals need to embrace and practice common values. Communication is important. That's why medical schools are incorporating interprofessional teamwork into their curricula and balancing technology and personal interaction. Although technology aids in communication, face-to-face communication still is crucial for effective teamwork. All right, so the dichotomy of inpatient and outpatient internal medicine. So these are two very different settings, and advanced care, emergency departments, and critical care units are equipped to handle critical cases, saving lives previously, and this is a really important role. Reduce hospital stays. Our focus now has shifted towards shorter hospital stays and managing complex conditions in the outpatient setting. It is said that we would have an improved outcome when patients stay shorter in a hospital because being admitted to the hospital for a very long time, um, one is very costly for the hospital and the patient, and also it puts the patient at risk for various complications like hospital-acquired infections, bed ulcers, and so on. So cost reduction and technology advancement. This shift has driven by reducing costs, utilizing new outpatient technologies like imaging, percutaneous catheters, for example, and minimally invasive surgeries have allowed patients not to be admitted to the hospital. They could just come in one day, have their procedure done, and go home the same day. And this has led to improved outcomes. Studies show that there is improved outcomes for patients managed outside the hospital whenever possible. All right, so if we are wondering what a hospitalist is and what an intensivist is, so these are the definitions. A hospitalist are internists specializing in inpatient care, providing acute care due to shortened stays. An intensivist is our critical care specialist managing and directing very ill patients in dedicated units. Um, so that's the difference. And the crucial challenge is to ensure continuity of communication between the patient's primary care physician and those managing their inpatient care. So this could be very difficult, especially when a patient is admitted and now they have to be discharged and follow up with their primary care physician. There might be some, because these are two different teams handling the patient, it might you might have some communication issues between the team. And that's why it's important that when patients are discharged from the hospital, a very detailed discharge note should be written for the patient just so the primary care physician would know um, the events that occurred while the patient was admitted. This could benefit the patient's care very much. Um, and there's these challenges in transitioning care, so maintaining communication flow through handoffs between outpatient and inpatient settings, critical care and general medicine units, medical and surgical services, hospital and home hospital settings, and hospital and outpatient settings. Um, this is still a challenge in today. These are just examples of what the intensive care would look like, and this is an example of what inpatient care would look like. All right, so multiple care providers transition between specialists and units can impact the traditional primary patient care physician relationship, but there are benefits of collaboration, effective teamwork among healthcare professionals, benefit patients, but the PCP role holds the responsibility for cohesive guidance. The primary care physician role, some roles include be familiar with the specialist techniques and objectives, ensure the patient benefit from specialist expertise and advancements, explain specialist role and reassure patients that they are receiving the best care, assure patients and families decisions are made collaboratively. The medical home concept promotes smooth transitions through team-based care, integrating primary and specialty care. All right, mitigating the stress of acute illness. So patients present with very life-changing events like cancers, heart attacks, strokes, and accidents, and this could be very frightening for patients. And the role of healthcare providers provide clear, calm, and consistent information repeatedly, reassure the patients, recognize and address patient anxieties about unfamiliar hospital environment, and this could be very challenging for patients because the hospital environment is unfamiliar to the patient, could be very intimidating. There's a lot of unfamiliar equipment, procedures, and numerous staff. The patient could be disoriented due to the illness, medication, and sleep deprivation while in the hospital. So the physician role is to be very empathic, compassionate, understand the patient's perspective, try to help the patient as much as possible through the process and the stressful nature of the experience. Also, the nurses are there to assist the patient, and they have a really important role because they would be spending more time with the patient than the physician. Guidance: navigate patients through the process to improve tolerability and recovery. All right, so we'll move on to medical decision making. So some crucial elements, deep understanding of diseases. So knowing your pathology really well, knowing the nature and typical course of various illnesses, differential diagnosis, identifying potential causes based on symptoms and knowledge from the history and physical examination and from diagnostic studies, using the scientific method, formulating hypotheses, gathering data, revising diagnosis based on new information that you you've obtained. So it's a continual process um, of ruling in and ruling out differential diagnoses. And we do an evidence-based approach as much as possible. So we utilize data from rigorous studies to guide decisions. So it's not just um, anecdotal um, experiences. It's not just that, it's from studies which were done previously. That's how we make the best decisions for our patients. So there are challenges too. So limited evidence. Not all decisions have strong evidence-based support, sometimes relying on expert consensus. Avoiding bias, counteracting the influence of anecdotal experiences, and focusing on objective data. So objective data meaning from guidelines and research that were done on the same conditions previously. All right, so while evidence-based medicine is crucial, good clinical judgment remains important, especially when evidence is limited. Weighing factors and uncertainties, and there are quantitative tools that physicians could use. Um, Diagnostic tests would reduce uncertainty and they would help to complement the history and physical examination done on the patient. All right, so next we move on to practice guidelines. What are practice guidelines? So the purpose is to they are evidence-based guidelines used to aid in diagnostic and treatment decisions and aims for better outcomes and cost effectiveness. So these practice guidelines are usually also rooted in research that were previously done. And some benefits, they provide a framework for managing specific conditions. They protect patients from receiving substandard care. They protect caregivers too from malpractice claims because if a physician base his treatment on a guideline, is more likely to be covered and protected. Help manage healthcare costs. There are limitations, so they can oversimplify complex medical scenarios. Sometimes patients don't present with one medical condition. They usually have multiple medical conditions sometimes, and one guideline will not be sufficient to help manage that patient. Uh, there are some different guidelines that exist for the same issue. So, for example, one guideline might state that you should start do screening mammography at one age, and a different guideline would say a different age. So there might be some discrepancy there. Some guidelines would state that you should use PSA screening for prostate cancer. Some say you should not. So those are some limitations, and it cannot fully account for individual patient needs and circumstances. So the key point is physicians should utilize guidelines thoughtfully, integrating them into practice. They are very useful, and but we should not blindly follow or feeling over restricted. And this is just an example of a practice guideline. So this is the JNC 8 guideline used to manage hypertension, high blood pressure. So just to take you through an example, how this guideline is used. So if a patient presents with high blood pressure, we could first start lifestyle modification as the guideline states. So like low salt diet, exercise more, weight reduction, and less alcohol use. If those um, changes is not sufficient to reduce the patient's blood pressure, we could go along the guideline based on the patient's demographic. So if the patient has no chronic condition, for example, like diabetes or chronic kidney disease, we could move down this path. And if the patient is less than 60, we move down this path. If the patient blood pressure is less than um, um, if the patient's blood pressure is greater than 140 or and the diastolic pressure is greater than 90, and if the patient is non-black, for example, then we could choose these one of these medications to start the patient on, like a thiazide diuretic, for example, HCTZ, or ACE inhibitor like um, uh, ramipril or captopril, for example. If the patient is black, then we could use thiazide diuretic or a calcium channel blocker like amlodipine, because the evidence states that patients who are black respond better to these medications and they do not respond better to ACE inhibitors, for example. That's what the evidence states, and the guideline, the GNC 8 guideline, incorporates that into practice. So physicians could use this guideline. So manage patients with high blood pressure. All right, now we move on to precision medicine. So the concept is precision medicine aims to personalize treatments based on individual characteristic and beyond just diagnosis. So the goal is to improve outcome and minimize side effects by using targeted therapies more specifically. And on the next slide, we'll see some examples of these targeted therapies. Evolution of clinical guidelines. So traditional guidelines focus on entire patient population with similar diagnoses. So when studies were done to generate those guidelines, they studied entire populations. They didn't study individual patients and how they differ. So precision medicine refines recommendation based on individual factors like genes, biomarkers, and other characteristics. For example, cancer treatment can be tailored based on genetic testing to predict individual responses to targeted therapies. So rather than using a broad-based chemotoxic regimen that could harm the patient's healthy cells um, also and produce more side effects, we've developed a lot of targeted therapies for cancer that's able to only affect those cancer cells. And now we'll see some examples. So some examples of targeted therapies. It is used in breast cancer. So this is trastuzumab or Herceptin, and this targets the HER2 protein overexpressed in some aggressive breast cancers. And using this medication, it blocks that receptor and it blocks growth promoting signals downstream, thus halting cell replication. So that's the use of this targeted therapy to decrease the growth of um, certain breast cancers. So another example would be lung cancer or lorlatinib, and this targets the EGFR mutation, which is a common driver in lung cancer. And this is an example of targeted therapy also. Probably the first targeted therapy that came out was the drug known as imatinib or Gleevec, which is used to treat CML or chronic myeloid leukemia. This targets the BCR-ABL fusion protein, a hallmark of CML, and halting its uncontrolled growth. So these are some examples of targeted therapies and how precision medicine is used in patients. All right, so the evaluation of outcomes. How do we know if we're achieving treatment goals for our patients? So objective measures, readily quantifiable parameters are used to assess treatment outcomes like mortality rate. For example, a low mortality rate would be equal to a good treatment outcome, and another one would be hospital stay. But these have limitations. They may oversimplify complex conditions and disregard patients' experiences. So there are subjective ways we could assess outcomes also by capturing the patient's perspective on pain, function, quality of life through interviews and questionnaires. So these are usually patient-centered and concerns are assessed like pain, functional capacity, sexual function, cognitive function, and overall well-being of the patient. So an integrative approach says that medicine requires consideration of both objective and subjective outcomes for comprehensive patient care. All right, so to evaluate those subjective concerns, healthcare systems use surveys and patient feedback to assess patient satisfaction, access to care, and communication with providers. So there's the HCHAPS surveys, and it's a widely used system to measure patient experience in hospitals, and it is publicly reported. And social media also is an emerging tool for real-time feedback of healthcare and sharing patient experiences to enrich information for best medical decisions. All right, so errors in the delivery of healthcare. So Reducing medical errors. The National Academy of Medicine advocates for fundamental system changes to improve patient safety. It is the hospital responsibility to implement systems that reduce medication error through electronic ordering or clear prescription writing. As you probably heard, some doctors' handwriting are really terrible, and this may result in miscommunication in their writing. So the electronic ordering system is really great in overcoming that issue. Standard procedures to minimize nosocomial infections like um, hand washing, antibiotic oversight, preventing surgical errors through protocol and checklists. No one wants to be operated on the incorrect limb, for example. Help patients avoid falls with appropriate medication use and assistance. So incorporating equipment like appropriate bed rails and avoiding too much um, sedative medication, which could result in falls. So the goal is to combine these measures to significantly reduce medical errors and save lives. All right, so we move on to the electronic medical record. So growing reliance on impact information technology plays a central role in modern medicine, including lab data access, almost universally accessed electronically for faster analyses. The EMRs, or electronic medical records, centralize patient information for improved care coordination and very fast access. Computerized order entry reduce medication errors through automated systems. Barcode medication tracking ensures accurate medication administration and inappropriate use of medication, for example, the use of narcotics. Interactive systems sends alerts and reminders to prevent potential medication errors. We have systems which could send error alerts if the patient is allergic to a medication, for example, to not administer that medication to the patient. All right, some benefits of electronic medical records. You would have improved access to information. EMRs would provide rapid access to a comprehensive view of the patient's medical history, including relevant data, historical and clinical information, imaging studies, lab results, and medication records. Um, Enhance quality and safety. EMRs could improve healthcare quality and patient safety by enabling clinicians to monitor and reduce unnecessary variations in care. Real-time insights. EMR could provide real-time information about processes of care and clinical outcomes, allowing for better decision-making. Challenges. Interoperability. Technological limitations hinder the easy transfer of patient reports across the healthcare systems. Maybe differences in software, or if another system is using a different EMR system, for example, that could be a challenge. Privacy and cost concerns about privacy and costs continue to limit widespread adaptation of EMRs in some clinical settings. As you know, patient information is very confidential, and there are some security measures that must be imposed when using the EMR. All right, so let's look at some additional challenges of using the electronic medical record. So you may have a patient-physician disconnect. The risk of reduced face-to-face interaction if not managed effectively. It might be more tempting to look at a patient EMR rather than actually obtaining information from the patient, which would help to build a patient-physician relationship. Time commitment and training. So data entry could be time consuming and requires specific training. Increased error risk. Pressured data entry may lead to shortcuts and errors. Disrupted information flow. Structure may not support the traditional narrative flow of medical information, and it can lead to physician dissatisfaction, increased workload, and potential impact on physician well-being. Um, to update data in certain electronic medical records is really time consuming sometimes, and this is an added workload to the responsibilities that physicians might have. Documentation is important. That's why it is so time consuming for physicians. So, in conclusion, balancing advantages with challenges is crucial for both optimal patient care and physician well being, and continued improvement in EMR usability and workflow is essential. With the advent of AI tools and so on now, I would hope that electronic medical records could start to incorporate these so it would lessen the burden on physicians. So a crucial point is information technology is a valuable tool, but clinical judgment is irreplaceable. Physician expertise and understanding of patient needs and remains essential to decision making. Um, Effective approach combining clinical knowledge with quantitative tools, examples, diagnostic tests, and guidelines optimizes medical care. And in this picture here, I'm showing you some examples of EMR. A very commonly one used is Epic. Cerner is another one that's commonly used. And we have others like Advanced MD, Practice Fusion, and Athena Health. Alright, so that's the end of the first lecture, and I would like to reference the Harrison's Principle of Internal Medicine. That's where I got the content for this lecture and the outline. Alright, so thank you very much for watching the video. If you like this video, please like and subscribe, and I hope to see you in the next video.